Hey everyone, today we're going to talk about lipophilicity as it relates to pharmacology. Don't forget to like the video and subscribe to the SimplePharm channel, where we break down pharmacology topics for nursing students, pharmacy students, and medical students. Let's go over some of the objectives and topics for this discussion. We'll cover some basics of lipophilicity, as well as administration, dosing, side effects and toxicity, and some of the clinical implications you may see. It's extremely important you understand the concept of lipophilicity, and once you know it, you can apply it to any medication. Let's also review some of the Greek and Latin terminology. This you should know. Lipo is fat, hydro is water, philo is friendly, phobo is fearing. When we use a combination of these words, we get more characteristics of some of the molecules we'll be talking about. Lipophilic is fat-friendly. Lipophobic is fat-fearing. Hydrophilic is water-friendly. And hydrophobic is water-fearing. Having a good understanding of these will help make the rest of the notes make a lot more sense. Every nurse, pharmacist, and physician should have a basic understanding of lipophilicity. The lipophilicity of a medication affects all pharmacokinetic and pharmacodynamic properties. Here, we have a glass of oil and water, or it can be thought of as fat and water. The layer on top is fat, therefore the top layer is lipophilic. The layer on bottom is water. Obviously, water doesn't mix well with oil. That's why we have two separate layers. Water is inherently lipophobic. Question: if you were to throw a lipophilic medication into this jar, where would it go? In the top layer? Will it stay in the middle layer or go in the bottom layer? Overall, lipophilicity plays a key role in ADME. If you don't remember ADME, check out one of our other videos for an in-depth description. Lipophilicity helps us decide the route we're going to administer medications and in which formulation we're going to use. It also helps us determine the dose. How much are we going to give the patient and how often? We want to make sure patients are getting a therapeutic dose and a therapeutic frequency so that we can actually treat the condition. Lipophilicity also plays an important role in toxicity. What happens if we give too much or too much for too long? Do we need to worry about accumulation in certain tissues of the body? What side effects could be a result? In terms of medication administration, lipophilicity helps us determine which route of administration is ideal or which to avoid for certain medications. For oral medications or by mouth, also abbreviated PO, some lipophilic medications are better to be given this way because they can easily cross the membranes in the gut and get into circulation. Some medications are even activated in the GI tract through metabolism. For IV medications or intravenous, the fluid in your venous system is primarily water. Medications that are highly lipophilic won't want to stay in the blood and will distribute to other tissues in the body. IV administration also bypasses first-pass metabolism. For medications that are applied topically, like patches, ointment, and creams, medication doesn't have to travel that far. There's a lot of fat cells at the surface of the skin. So this is great for applications for localized pain, but it's not great for medications that need to be distributed systemically. Here, let's get a basic look at a dose and plasma concentration graph. In this graph, the area between the peak and the trough is the sweet spot, the therapeutic target, or the concentration we want to achieve to treat the condition. When the concentration falls below the troughs, we are subtherapeutic and not effectively treating the condition. When the concentration is too high and above the peaks, we may be in an area where toxicity is occurring and can cause side effects or direct patient harm. The middle is the perfect balance of dose and frequency to maintain therapeutic concentrations without toxicity. You have to consider the lipophilicity of a medication when making dosing decisions to ensure you're reaching a therapeutic concentration for the appropriate duration. To do this, we look at a medication's volume of distribution, or VD. You won't have to calculate this in practice, maybe for an exam. It's the total amount of drug in the body divided by the concentration in the blood. The higher the VD, the more lipophilic a medication is, and will distribute more so to the tissues and organs. The lower the VD, the more lipophobic a medication is and will want to stay in the blood. If we look at the equation to calculate half-life, all things being equal, as the volume of distribution increases, so does the half-life. Medications with a high volume of distribution will have a long half-life, and these medications will stay in your system for a long period of time. This is important because lipophilic medications can accumulate in your tissues, specifically some of your organs. For dosing, lipophilic medications require less frequent dosing, sometimes daily, weekly, or even longer, whereas lipophobic medications are going to require more frequent dosing, like every 4 hours or every 6 hours. On the right, assuming a patient received the same dose of a medication, medication A and medication B, which medication has a higher volume of distribution? Since more of the drug is distributed within the brain, an organ, primarily composed of fat, drug A would have a higher volume of distribution. In terms of toxicity and lipophilicity, some medications are toxic or harmful by themselves. There's also medications which are metabolized into toxic substances. Lipophilic medications or their metabolites can accumulate in your tissues over time. The longer a toxic substance is in your tissues or in circulation, the more time and opportunity for the substance. For example, let's look at amiodarone. Amiodarone is a highly lipophilic medication that's used to treat arrhythmias. It has a volume of distribution of over 5,000 liters. Remember, high is anything over 40 liters. The half-life of amiodarone is 25 to 100 days, in some cases even longer. It stays in the tissues for a long time. On top of that, amiodarone and its metabolites are toxic, and they can cause extensive lung damage and liver damage. If the medication continues to accumulate due to too frequent of dosing or too large of a dose, a lot of damage can be done to the patient. For these reasons, monitoring for signs and symptoms of toxicity is extremely important. Let's put it all together. This lesson should give you a solid understanding of lipophilicity and why we care about it in pharmacology and healthcare. It's important to know the terminology so you can have a better understanding of how medications are distributed after they're administered. The route of administration is one of the first steps in ADME, and it's very important to understand lipophilicity and how medications are absorbed. Understand why we use the routes we do, including the dose and the frequency, and how lipophilicity plays a role into obtaining and maintaining a therapeutic concentration for our patients. Remember how volume of distribution and half-life are directly related. The higher the volume of distribution, the longer it's going to stay in your system and the longer the half-life. Think about where highly lipophilic medications will tend to accumulate and how that may lead to prolonged exposure and potential toxicity. Thank you for watching. Please like and subscribe for more pharmacology videos geared to healthcare professionals, and leave a comment if there's a topic you'd like to see